I first apologize for the delay, and I'm very excited to be able to show you what our team has been working on a pilot study for lung ultrasound in systemic GI. So first, I wanted to call your attention for the different imaging techniques that you can use for the assessment of ILD. And so we have checks X-ray, which we all use. It's easy access, not invasive. However, it has a very low sensitivity, particularly in early ages of disease. And so like this X-ray here, we see is very abnormal, but we only can detect that when it is late in the disease process. We could also use like chest CT, which right now is taken as the gold standard for like in the imaging perspective for ILD. However, it has a relative high cost and radiation exposure. We need to be conscious about that. And depending the area where you are, you're gonna need a special equipment. This is an example of a patient in which we see areas of abnormalities here related to ground glass opacities. But when they did an X-ray in this patient, the X-ray was normal, again, showing that that is not enough for picking up. Now, lung ultrasound is one technique that they are using nowadays more in adults and has several advantages that it can be a point of care modality, is not invasive, radiation free, short duration, and for us it's very important that it's friendly in children. It has a relative low cost, and based in adults studies, we're seeing that has a very good validity, reliability, and feasibility. However, we need to acknowledge that more studies are necessary. So this is the same example of the patient as I was showing you earlier. And this is the lung ultrasound and that patient, which we're seeing the pleural overlining is thick. And I will get into that a little more. So when we hear about that they are doing it in adults, we wanted to understand if lung ultrasound could be a technique that we can use in children. The scanning technique that we use nowadays, we see 14 different areas on the chest. This cartoon here shows you that we look into 4 areas in the anterior wall of the chest and 3 on the posterior. And doing that, we also are able to assess the superior, medial, and inferior aspect of the lung. So those that are not familiar with lung ultrasound, this is an example of the scanning technique. So when patient we're doing in the posterior chest, the patient is sitting straight and we take a video. You can see here about 5 seconds or so longer, so we can assess later. When we're doing the anterior chest, the patient is just laying down. And usually it takes about 10 to 12 minutes to complete the study, depending the patient, and we need to take some breaks. So this is an example of what you usually see for a normal lung ultrasound exam. So we are assessing is the movement of the pleural against like the chest wall. And it has been described like the pleural, you see like a homogeneous twinkling, sparkling, looks very nice and homogeneous. But when you have problems on such as interstitial lung disease, areas of abnormalities can include like this granular lesion, which is thickened, pleural overlining, or maybe there are discontinuations on the pleural overline, which we can observe here. This is a very important finding that some of you, if you're familiar with lung ultrasound, are the beam lines, which are taken as a sensitive finding to talk about abnormalities. So our group decided to conduct this pilot study in patients with SJIA and lung disease. And our objectives were to describe the findings in patients with known systemic GI lung disease. We wanted to see the feasibility of the lung ultrasound and also to try to describe that correlation of lung ultrasound with the chest CT findings. We enrolled patients with non-lung disease, as I said. All of them got a lung ultrasound, completed a feasibility questionnaire, and then we reviewed the chart. We enrolled a total of 9 patients and 6 healthy controls. All subjects that we approached to be included in the study, they agreed to participate. And then for the feasibility questionnaire that was completed by all the families, they noted excellent tolerability and feasibility. I want to share with you some of the findings that we had in our patients. So this is a child, 5-year-old with systemic GI that did have abnormalities on the chest CT. If you remember, we talked about a nice overlining before, but now these look thick and is just below the pleural, you see these areas of consolidation, like subpleural consolidation, which is a finding that we're seeing is more specific of patients with SJI Lyme disease. Over here, we can observe again how the granular interrupted pleural overlining looks like. One other example for us is this patient. He's 10 years old, has systemic GI with different abnormalities at the chest CT as overlined here. And our lung ultrasound findings, so now this is more those cavitary lesions that I was describing earlier in the pleural overlining. And then in another area of the chest, we were seeing these subpleural consolidations, and then that the parenchyma actually looks like obscure. And that is a relationship of thickening of the pleural line along with these subpleural consolidations. What is surprising in this patient is that in another area we scan of the lung, actually it looked quite normal. And then when we compare these findings with high resolution CT, we saw that the patients that had less severe or greater findings in the lung ultrasound, actually the chest CT and those was also more milder disease. So with our study, we found that lung ultrasound is a feasible imaging tool in children from even early age. Our youngest patient was 2 years old. Lung ultrasound revealed abnormalities in the pleural and the subpleural space that appear to correspond to the chest CT findings in all children with SJI lung disease. And this study suggests that lung ultrasound could maybe provide a low-cost and a safe modality for screening and monitoring of SJI lung disease. Now, we acknowledge that this is just a pilot study. It was described and a description. So we're looking for larger studies to see if we could determine the sensitivity of lung ultrasound for systemic GIA. In the screening, also how it correlates with biologic markers of disease activity. And we would like to see how sensitive is lung ultrasound for change over time or maybe assess response to therapy. So those will be our next steps. And I would like to acknowledge our team, collaborators, and of course, all patients and the Systemic GI Foundation that help us with this study. That's all I have. Thank you.
I think there's a few questions actually, if you look in the chat.
Yeah, you have two windows open. Oh. So, okay, very good question from Randy. So this was just a descriptive study, and we don't have side-to-side comparative findings to say absolutely this area was abnormal on lung ultrasound and chest CT. We had 2 or 3 patients that actually the chest CT was very tiny in comparison with lung ultrasound. So we did see that in those patients, it does correlate. And there are findings on lung ultrasounds that are more related with fibrosis and chronicity. And those patients actually had more honeycombing findings on the high resolution CT. And then were more findings like inflammatory findings, like ground glass opacity, that we saw those findings in lung ultrasound. So it's just a pilot study. We don't have many data to answer that. So we did this study along with Stanford. We partnered with an adult rheumatologist that is doing a lot of lung ultrasound. So we had some patients from Stanford. That's the sites that were involved. And thank you, Vivian. And then we actually were the ones that did the ultrasound in clinic. I did it myself. It took about, as I said, like 12 minutes plus or minus to conduct. And I think it's an easy technique to learn. As ultrasound, you need to have some certain curve of training. But we hope that moving forward, we could collaborate with other sites. And this modality to guide biopsy. That will be nice one day, right? I think that's what sometimes they do it for, like when you have pleural effusions, and doctors actually and the ICU use that to take out the fluid. Am I missing any points here on the questions, Rashmi?
No, I think basically the questions are about a little bit of like expanding this to other centers. I know other parents who are getting frequent lung CTs are very curious about this, if there's a way to do this. And I've even thought about it. I mean, could you do a session? Could they find the lung ultrasound people at their centers, and then we facilitate some kind of session to help other centers start doing this? Are centers interested in this?
Yeah, I think, it's very feasible to perform. And that's how we studied first just with Stanford. But right now we're talking about the training is not as difficult, or not that musculoskeletal ultrasound is difficult, but it's a technique that you can teach and learn. And that's how we oversee, like, this is a technique that we can do every visit or every 6 months and follow and see what we find. And as the discussion this morning and what is being happening, we need a lot of patience and we need to be able to collaborate. So that's another reason we're coming to the foundation and see how we can partner together.
Sure. So maybe as a follow-up, we'll try to actually have a session where we have different centers. I'll try to make that happen.
So Patricia, Rashmi, one quick thing. Patricia, I don't know if you're aware, but there's a ultrasound work group in CARA that meets pretty often, led by Ed Oberle. I don't know. I'm sorry I missed your presentation. I don't know how relatable the ultrasound you were doing is to MSK ultrasound, but he teaches MSK ultrasound and they meet pretty regularly. So it might be good to reach out to him if you're looking to expand to other places.
Thank you, Vincent. I'm excited to know that our CARA group is going out there, even for you guys. I'm a very active person in that group. And we just studied a small session between the PITS, that network, but that's a network that we can use to facilitate other sites to come involved. So thank you.
Sure. I want to maybe add one more thing. So I think my son had a CT recently, and then right around the same time, I think my son is one of the few people you've done twice. And also right around the same time, this was a plan with Dr. Grom. We did the CT, we did the lung ultrasound, the 6-minute walk test, the overnight pulse oximetry. And I think our current thinking is that we'll try to repeat the combination of the three. We also did the lung PFTs, but actually Dr. Grom, maybe he can speak up. He felt that the combination of the lung ultrasound, the 6-minute walk test, and the overnight pulse oximetry was pretty informative. And all three are non-invasive, easy to do, and we could do that very regularly. And it might be a good way to keep track.
Yeah, and I haven't commented too much about it. We have 2 patients that we've been very lucky to follow. One of is your son, and we actually were able to see. I think I show you, Rashmi, that we have 1 point, and we actually saw a difference on the lung ultrasound. What is the meaning? How we follow? That's to be determined, but it's very encouraging that it shows a difference over time.
And it parallels some improvement in terms of functional tests as well. So I think that was exciting.
Yeah. Yes, I
But
think.
to me, sort of the major advantage here is that, we kind of can define a risk group for the lung disease, and we are often hesitant to do high resolution chest CT early because of the possible radiation and those kind of things. And I see it as a very safe and alternative approach to high resolution chest CT to do this initial screening in a larger group of patients early in the disease.
Well, thank you. Thank you so much.